I think the DC in general will continue to lag behind the rest of the country in its movement towards value. But I think something very exciting to watch is what's happening in Maryland with their hospital rate setting system through moving into global budgeting. And I think Maryland could turn out to be an area that is very innovative and through a completely different mechanism is pursuing some really changes with high potential.
I'm Leighton Coe. I'm the interim chair of the Department of Health Policy and Management. And before I go too much further, first I want to acknowledge support from the Jane Koskinas and Ted Giovannis Foundation for Health Policy, which is sponsoring this series. They did so last year. This is the first of this year's talks for the Health Policy Dialogues. I think that's what we're calling this series. Today's distinguished speaker is Paul Ginsburg, and then our discussant is Mila Kaufman, who's disappeared somewhere. But she'll be back, I'm sure, I have no doubt. But before we go much further, let me first ask Ted if Ted wants to say a few words.
If you don't know about the foundation, go to our website, it's jktgfoundation.org. Sign up to get the newsletter. It's all free. We do a lot of policy research, and some of your faculty here is actually working on some with us right now. So we have a process where we give out dissertation support grants for those who are doctoral students. So we haven't decided when the 16 version of that's going to open up, but it'll probably open up soon. So with that, thank you all for coming. And certainly thank Paul for coming and giving us his wisdom about what we found out with the market study in Washington, D.C.
For many of you, you've been around Washington for very long at all. You know Paul already. Paul is currently the Norman Topping Chair in Medicine and Public Policy and a professor at the Saul Price School of Public Policy, University of Southern California. Yet nonetheless, despite that apparent title, he is not based in Southern California. He's still around here. So he is still one of these denizens of Washington. But, you know, people have known Paul in different incarnations in the past. Shortly before switching over to USC, I think it was your immediate position just before, he was the director of the Center for Studying Health Policy Change, which was a very large project that did a variety of things, I think in part related to some of the stuff that he's talking about today. Earlier, he was the executive director of the Medicare Payment Commission, where he helped, sort of provide advice to Congress about Medicare payment policies and related topics. Earlier, before that, he was at CBO, RAND, and so he's been a key person in understanding health policy, health economics at the federal level, and by virtue of some of the other work, now sort of extending down to local levels for a long while too. What I guess I want to sort of say in general is that part of what I think is great about the talk that Paul will be giving today, which has to do with sort of the healthcare marketplace in the national capital area, and I think you have some comparisons to some of the Southern California market also, is that it's easy because we're in Washington to think of things like everything is the same across the U.S., and that's not true at all. I would say that some of the work that Paul has done, and a lot of the work that the Center for Studying Health Systems Change did, I view as being sort of like health cartography, really trying to sort of map out what are the differences between areas, how does that affect things, and understand those differences somewhat more closely and how they reflect a evolving healthcare market, how that should also be important in understanding policy. Our discussant today is Mila Kaufman. Mila is the executive director for the DC Health Benefits Exchange. So in this regard, she directs the Health Benefits Exchange. So she's, whereas I might say that Paul is a cartographer, Mila now has to navigate the healthcare market in the local area. And of course, the DC Health Benefit Exchange, so it's primarily focused on DC because of where people live in DC, also includes having to understand something about the healthcare marketplace in the region, because that's where many of our consumers also live or get care. So Mila will be giving comments later. Mila, before she was the director of the Health Benefits Exchange, was immediately before she was a research professor at Georgetown, that university otherwise remains anonymous, not too far from here. Before that, she was the insurance commissioner for the state of Maine. And then before that, I think you were at Georgetown before that too. And then at various points did a stint in the White House and the Department of Labor, is that right? So Mila is also, aside from that brief period in Maine, she went mad for a bit, has also been in the Washington area for a while.
I've been doing site visits, as Leighton mentioned, for a long time, actually starting in 1995. And the Center for Studying Health System Change had a project where it randomly chose 12 metropolitan areas across the country and followed them. Maybe every 2 or 3 years went back. And later on, did this project more intensively in California, getting me ready to join USC, I suppose, where we would study 6 metropolitan areas in California, not including the one we were studying for the Robert Wood Johnson Foundation study. And I've always wanted to do a site visit study of the National Capital region for 2 reasons. I mean, one is the basic reason of these studies have proven pretty interesting to the local people in the healthcare systems, but also I saw it as an opportunity to take the federal policymakers, and it's a way, and by having familiar institutions, familiar hospitals, insurance companies, as the actors in this story, to actually pull them into some of the dynamics that are happening around the country. And so I was very grateful for the opportunity with funding from the JKTG Foundation to embark on this project. And and the presentation I'm going to give tries to keep these 2 audiences in mind, figuring that some of you are in one or both of those audience, and hopefully be useful to you. I actually have a lot of experience of making presentations to local groups in the areas we've done site visits on the report that we wrote on their community, always quite uneasy getting up before these, recognizing that, well, the people in these audience were some of our best sources of information, and started focusing on, what can I give to them, other than confidence that I got it right, but they wouldn't illuminate them. But what might illuminate it for them is show them, is this area, the norm on this dimension, or is it an outlier in some ways? And basically, how does the area differ on that? This DC site visit got a lot on the differences, and that this area is not at all typical of areas. In some dimensions it is, but in others it isn't. And that was, I think, one of the surprises in doing this visit. So what we did was use, a little uneasy, this huge screen. I guess you can still see me. That we used our established site visit approach that we've been refining over many years. And in this case, we interviewed about 40 executives of organizations and Vantage respondents. And what I mean by a Vantage respondent is that if you're an executive of a hospital, the interview is mostly about your hospital and what it's doing, how it's interacting with other hospitals, insurance companies. But the Vantage respondents are distinct because they are people who are not associated with a particular, in this case, Washington area institution, but really know the market for some reason and can be somewhat objective about it. And these people tend to be consultants. Sometimes they're academics, although I found over the years that the academics that actually really know the local healthcare market are fairly rare. And we had a couple of disasters after, for years, phenomenally enjoying, I don't know if anyone knows J.B. Silver, who's at Case Western Reserve. That's always a pleasure to talk to him about Cleveland, because he wasn't just someone who studied it, he was actually a player in the Cleveland market, but articulate enough to tell us about it. So anyway, the Vantage respondents provided some of the most interesting reflections about how Washington, D.C. is different from other areas that they work in or are familiar with. And what we always do is ask respondents at the end of an interview, well, what's important in this market that we haven't asked you about? And sometimes we get very interesting answers. And in this project, the answer often was, well, you know, that's when I have to tell you how different this is than other markets. Usually in the dimension that it was actually way behind other markets in the movement towards population health, value-based health, et cetera, and for reasons that are actually not that hard to understand. So this is the market we covered. This is, I think, is not quite the metropolitan area, but this is basically, you know, DC and the suburban counties that are close to it. So in Maryland, it's just Montgomery and Prince George's. In Virginia, it's Arlington, Fairfax County, Prince William, and Loudoun County, and that's where we stop. And so this is the market. It's about it. Frankly, if the market was much broader, I don't know if we'd have that much more to tell you about it, because it's really hard to get, you know, to go into another county that's a rural county. So anyway, that's the market, and this graph, you know, also just marks where the hospitals are. Of course, it's missing something. It's missing a big river here. So these hospitals that look like they're close to each other, of course, they're not in a practical sense because there's no bridge there. So the market background. The population in this area is very affluent on average and very highly educated. And there are 4 counties, they're Montgomery, Arlington, Fairfax, Loudoun, that stand out nationally as far as you know, how high their incomes are, how high their education levels are. And of course, the area has notable disparities, particularly in DC and in Prince George's County. The economy is strong, it's very stable over time. Unemployment is traditionally low, as it is now. Of course, it's anchored by the federal government, but also it has a very large professional services sector. And, you know, this includes, you know, various vendors that sell to the federal government, includes all the lawyering and lobbying, and, you know, a developing tech sector, you know, IT and defense-oriented in Virginia, biomedical-oriented in Maryland. And the competition for high-wage labor is very keen. So the health benefits, not surprisingly, are quite rich. The federal employees' health benefits program does set a very high benchmark, but actually many employers, we found, exceed what federal employees are getting. And, you know, these are the law firms, the lobbying firms, the trade associations, the foundations, the tech firms. So this is an area with very rich health benefits. And I think one of the reasons is that there's been very little motivation to try to get healthcare costs down. They're much more concerned with competing for these high-skilled, high-wage employees than they are in saving money on health benefits. And because the earnings are so high, for the most part, health benefits are a smaller part of the compensation package. Again, less reason to do things which are going to get employees angry and get them to consider leaving and going to another employer. So that's why you just don't see that much activity. On the commercial health insurance market, I would characterize the approach by employers as quite conservative. You know, I mentioned the lack of interest in cost containment, so you see lower rates of high deductible health plans and much less in the way of narrow network plans. You don't see the large employers here pushing for innovation. And, you know, this goes back decades, but the Federal Employees Health Benefits Program is a very passive purchaser. You know, its approach, and it was a huge innovator, I guess, 40 years ago, I don't think it's changed much since, was let's get the employees a wide choice of plans, including HMOs, and they do that very efficiently. The contrast to CalPERS, which is the California, I think, Public Employees Retirement System, is striking because CalPERS is very much an active purchase. It's almost a difference when you think about insurance exchanges, how most exchanges in the country under the Affordable Care Act are passive. They just, you know, offer all the plans that meet the qualifications. California has an active exchange, which means that they actually have insurers compete for the ability to be offered on the exchange. And they also have done other things. They decided that they didn't want a million different benefit designs. So for the Silver plan in California, the exchange says this is what the benefit design will be. And all of the carriers offering Silver plans offer that same benefit design. The reason they do that, to make it easier for consumers to compare plans and make good choices. So anyway, this whole culture of a very active CalPERS, the active exchange under the Affordable Care Act, that's the, you know, the enormous contrast with this area, which has much more passive approaches. This is a traditional PPO market, except for Kaiser Permanente. You know, the PPO share of the market, I believe, is fairly high. Deductibles are moderate, and provider networks are very broad. Commercial health market is somewhat competitive. You know, the largest insurers are CareFirst, Blue Cross Blue Shield, you know, which covers most of the national capital region. It doesn't cover all of the Virginia area that I had on the map. I think when you get a little further out from DC, it becomes Anthem, you know, the Virginia plan covers that. But they have about 40 or 50% of the market. They're particularly dominant in the small group market. They have more competition in the large group markets, and their key competitors are United Healthcare, Aetna, and Cigna. And this actually is a story I've seen in a lot of other parts of the country. Why is United the #2 plan in this area? Because it acquired a substantial regional plan. Was it called Mid-Atlantic Medical Service, MAMC? Medical Service. Yeah, so it acquired that a number of years ago. It was not at all an antitrust issue because United had almost no share in this market before that. So it probably, frankly, made the market more competitive because United was probably able to do more with the footprint that MAMC had than MAMC could have on its own. And then Kaiser Permanente is less than 10%. We didn't find it had much influence at this point on the rest of the market. And again, that contrast with California or the West Coast is enormous because in California, you know, Kaiser's market share is, the commercial market is probably something like half. And it's had a profound impact on the rest of the delivery system, which has long been doing a lot of things to be able to compete better with Kaiser. So now it's possible Kaiser will become more influential here over time because I do expect it to become more important. So this says that the market is most competitive for large groups and the self-insured. And what the national plans are offering to compete with CareFirst, because CareFirst probably has an advantage of having the lowest rates that it pays to the providers that are in its broad network. Basically, it's the data capabilities and the seamless national networks and that's not specific to this market, that tends to be where the national plans have an advantage over the local Blue Cross Blue Shield plan. And we don't see much innovation in product design. Nobody's asking for it. Presumably, the national players have innovative designs that they're just not rolling out in this area. They have to have them in some of the other areas that they operate in. There's not much interest in them here. Care First, of course, has had pursuing this, to me, very important innovation that I'll mention later with its patient-centered medical home. Now the markets, this is a very segmented market. We have Northern Virginia, the district, and suburban Maryland. And that, there certainly is some overlap in these submarkets, but the geographic segmentation is important, especially between Northern Virginia and the district. Somehow having the river there, you just don't have a lot of people going back and forth for medical care. Now, we shouldn't get too carried away with it. There are a lot of people who live in Northern Virginia and work in the district, and, as like me, and for many years, I got my care in the district, and my kids got their care in Northern Virginia. So there's certainly some. There are two major systems in this area. There's Inova out in Fairfax, and MedStar, which is in Baltimore and a lot of Maryland besides this area. What's very unusual for this area, and I have no idea why, is that many hospitals are parts of systems from other areas. So there actually are very few independent hospitals here, but there are a lot of hospitals that are part of a system from Virginia Beach, Tidewater area. Johns Hopkins now, of course, has two hospitals in the area. Virginia Hospital Center is a very interesting story about an independent hospital where I think back in the 90s where there was a point where hospitals were all panicking around the country about the need to be part of a system, and this is the first managed care boom, and they actually created some agreements, a joint venture with HCA, and the agreement actually had a clause that in 6 years the hospital could decide to get out of it, which it did, because it became apparent by that time that in many areas of the country a well-located independent hospital could do fine. And I think Virginia Hospital Center, which is quite big now, it's about 500 beds, seems to be doing just fine. Anyway, the hospital market as a whole is in general less consolidated than other markets. Although again, when you start looking at segments, you might say, well, Northern Virginia is fairly consolidated. If you just look at that, Inova's share is pretty large of their hospitals. Ambulatory care networks are expanding now. There is a lot of competition in the provider sector now, and especially in the affluent markets in Northern Virginia. And I would say that this is basically a fee-for-service strategy to drive volume, like we would see all over the country. In fact, a lot of things that providers are doing, it's hard to really say, is this really still part of fee-for-service, and this is what you do to generate more revenue under fee-for-service, or is this preparation for population health? And, in a sense, it's really both. I think here, the fee-for-service strategy is probably more important, but, to the degree they develop ambulatory care networks, that is a useful building block. And what I'm seeing now in Orange County, California, where I recently had a site visit, is that the major hospital systems have been doing a lot of joint ventures and as well as acquisitions of physician organizations and outpatient facilities in order to be able to offer coverage of the county for, say, a direct contract they have with an employer, or for a narrow network that wants to, feel that, well, if you put this hospital system in the network and don't have the competing hospital system, wanting to feel assured that the hospital system they have is actually providing coverage for the whole county. So in a sense, that's being driven by population health. I think here it's being driven by, a race to get well-insured patients with profitable conditions, or, to get the specialty care for the well-insured patients. Hospitals have been exploring ownership of health plans. MedStar has a significant Medicaid plan, and now it's developing Medicare Advantage plans. Inova has a joint venture with Aetna to develop insurance products that are branded with Inova's name, but administered by Aetna. I've been expecting, and I guess this is testimony to the market, that when a major hospital system gets together with an insurer or even starts its own plan, the main reason for doing this is to be able to offer a narrow network plan developed around the system and others that it has affiliations with. Inova actually has not done that yet, except for the product offered to their own employees. And maybe it's just a judgment that there's less interest in that model in this area than in other areas which have taken that step of sometimes on the exchanges offering a narrow plan built around that system. And we see increasing physician employment, particularly Inova, MedStar, and Johns Hopkins have been doing this. Now, in the physician market, this, like most areas, historically it's been a market of small practices. In this area, the commercial payment rates for physicians are fairly low. It's not unusual. You see it in a lot of large metropolitan areas that, often for the small practices, the commercial rates are actually lower than Medicare. There may be 90% of Medicare or so, and that's the case with this area. Of course, larger groups are able to negotiate higher rates. And what we've seen in this market is, as in most other markets across the country, increasing consolidation of physician practices. There are two large medical groups now. There's Kaiser Permanente and the George Washington University Medical Faculty Associates, which we understand began as the George Washington Faculty Practice Plan, but now is no longer affiliated with the university. And it is a very large group with a very heavy emphasis on specialists. And then we have hospital-owned groups, by MedStar, Inova, and Hopkins. But except for MedStar, the groups that the hospitals own are not that large a portion of the admissions to that hospital. So for Inova and Hopkins, still most of the admissions are coming from physicians who are not employed by those hospitals, but just have staff privileges. There's been experimentation with new models in the physician market. One of the things you see a lot of here, particularly in the more affluent parts of the area, is physicians opting out of insurance networks. Often they'll say, we don't take insurance. I think what this really means is that we're not in any networks. We'll help you file your claim, perhaps. But we also do see some distinct types of concierge practice in this area. And I say distinct because, the type you hear about the most nationally is a concierge practice that charges a substantial annual fee for patients to be enrolled in it, and also offers much more elaborate service so that the patient panel is much smaller than a typical physician practice. And, it really generates concerns about, taking all this physician capacity out of the delivery system for most people. What we also see here, and I haven't heard about it as much in other areas, is things like practices where the panel size is about the same, but the practice is asking for something fairly modest, like $200 a year to be in the practice. The practice I go to doesn't have a requirement, but they offer a portal. And they say that, you can have extra privileges. You can email your physician if you pay a few $100s a year. But you don't have to. We'll still take care of you the same if you don't. You can make your appointments online if you're in that. So there are these, let's call it low-key, limited concierge models in this area that I think are fairly common. Physicians are banding together in looser organizations. They've formed some independent practice associations. There's one that's in Fairfax County that's mostly primary care groups that got together. Basically, what an IPA does is it will often contract with insurers on a risk basis, say for enrollees of an HMO plan. Usually it can't do this for a PPO because antitrust restrictions prohibit it. You see a lot of very important IPAs in California and in Massachusetts. I've never seen them being important in other areas, and I believe the reason you see them mostly in those two states is that those two states had and continue to have a very high share of HMOs in their commercial population. And there are historical reasons why they do. California, everyone was used to Kaiser HMOs, and actually the HMOs in California often historically had very broad networks and had very well-regarded famous physician groups in their panels. Massachusetts had hospital rate setting in the 70s and I guess part of the 80s. I don't know when they ended it. And there was a wrinkle in that system which, allowed a health plan to pay hospitals less only for HMO patients. So you have a lot of HMOs in Massachusetts. We used to call them, since we did site visits in Boston, HMOs in name only, because they had very broad networks, very few restrictions on the patients. It was really to get that ability to get lower rates from hospitals. So since IPAs can contract with HMOs, that became the opportunity for IPAs. PPOs they're not allowed to contract with, except if they get special permission. We've also seen some federated models where it's often some large, like you see this in orthopedics, where some large groups will get together, not really merge, but just share administrative expenses and do their IT and their billing together. And I said management services contracts. I'm not sure what I had in mind. Maybe it'll come up in discussion. We see some interesting collaboration with health plans. And I think the Care First, Blue Cross Blue Shield, patient-centered medical home model is a very intriguing model. For those not familiar with it, the intriguing part is not the fact that they have some extra payment for medical homes, but the fact that they have a system that puts the medical homes at risk on an upside-only basis for global payments. So in a sense, if a primary care practice's patients have overall lower use of services than they were projected to have, they will get a substantial bonus for that. If they fail at that, they're not penalized for it. So, And I'm told, but the expert on evaluation is sitting here, that 80% of primary care physicians in this area who are in the network in Care First participates, and that there have been some substantial revenue gains for many of those physicians. I would say that the changes in the market have been slow. What often people talk about as a pass-through environment where, costs go up, insurers raise their premiums, and they don't threaten most employers, so the employers say, okay, they're not going to demand more aggressive actions by the plans, such as a narrow network. And also, very substantial lag behind other markets in payment and delivery models. So we don't see much provider risk sharing or population health management experience. There is some ACO activity here, but it's fairly limited, more limited than other areas. And I think their key exceptions have been, of course, the Maryland rate setting system, which has always been, important, apparently quite successful over time, and embarking on this very exciting global budgeting or global payments initiative under its latest Medicare waiver. And I guess there have been some writing in the New England Journal of Medicine recently about the first year. Kaiser has been getting extensive support from one of the most successful Kaiser plans in Northern California. This is the medical group, and I think, at least I'm expecting, I think there have already been substantial advances in Kaiser here, and would project further advances. Interesting relationship, which I didn't put in the slides, between Kaiser Permanente and the hospitals. Kaiser does not have hospitals in this area, and like it does in California. And the model that Kaiser pursues when it contracts with hospitals is that Kaiser doctors actually go into those hospitals and take care of their patients for the most part. Some hospitals weren't comfortable with that. And but some of the hospitals that have that actually see real positives to themselves if they learned from Kaiser how to do those things. And I mentioned the MedStar health plans as another exception to that slow-moving trend. I want to say some things about care for low-income people. And of course, as you know, the jurisdictions, the three, have strikingly different approaches to Medicaid coverage. And the DC and Maryland's had very expansive Medicaid programs even before the Affordable Care Act. And one of the things that meant is that, when the Affordable Care Act kicked in, and of course they expanded it, it actually had a less dramatic impact on the size of the Medicaid programs, because a lot of people who would not have been in Medicaid in other states were already in DC and Maryland, particularly DC, which was more expansive than Maryland. And the Virginia Medicaid program, has very tight eligibility, and of course no ACA expansion. And as I monitor the news nationally about ACA expansions, I'm thinking Virginia is really becoming an outlier. That states that are much redder than Virginia are already in the program, having expanded often under waivers with the administration, or are very actively considering it. And Virginia seems to be really gridlocked on that. Medicaid managed care, though, is mature in all of the jurisdictions. They've all used it as the predominant way of paying for a long time. DC, our report reflected important changes in the plans of how DC chartered was replaced by AmeriHealth in response to scandals and low poor performance. Turning to the delivery system for low-income people, the safety nets in the different areas are distinct. And this actually is something that's seen in other areas. If you go to the San Francisco Bay Area, the safety net in San Francisco is quite distinct from the safety net in Oakland, or I should say San Francisco County and Alameda County. I guess just, fairly much the norm. So it's like other areas. This area now has no public hospital since DC Gen closed a long time ago. And really, there are a variety of mainstream hospitals who are serving a safety net role in their particular geographic area. So they're serving the people who live in the area of that hospital. Each of the jurisdictions has very extensive community health center capacity. Probably it's most extensive in DC. Actually, one thing I'd be interested if anyone knows a lot about the safety net in DC is that one thing that I noticed recently in the San Francisco Bay Area is that the safety net in San Francisco is extremely well funded, much more so than in Oakland, and part of that is the local philanthropists who are probably more familiar and live closer. San Francisco, I don't know if I guess we don't have as many billionaires in this area as they do there, so I don't know if that's something that could happen here. Anyway, I think the largest access gaps are in the southeastern part of DC and in Prince George's County. And this is something that is in every area I go to, that access to specialty care, mental health care, and dental care is very difficult throughout, for both uninsured patients and for Medicaid patients. And not much safety net collaboration in this area. That's somewhat different. There are some areas where the safety net providers in an area collaborate a lot more. The ACA's impact on the safety net, I would say it's muted. I mentioned before that relatively small increase in Medicaid enrollees and really only limited demand in this area, I think because of the expansive Medicaid programs in subsidized coverage through the exchanges. And there are some signs that we saw of increased competition by providers for Medicaid patients. And one of the things that I think has helped foster this is that the provider payment rates in DC and Maryland for Medicaid are fairly high, pretty close to the Medicare rates. Some hospitals and community health centers are forming integrated networks to care for this population more effectively. But there are concerns that were expressed to us about the viability of some of the Virginia community health centers without a Medicaid expansion. I think that's it.